right, so our study is traumatic brain injury epidemiology and rehabilitation in Ireland. And the agenda is we'll talk about the background to the project, the study aims, the challenges, and also the expected outcomes. So the background to the study then, the inception of the study came directly from the NGOs Acquired Brain Injury Ireland, specifically Grania McGettrick, and also Richard Staples at Headway. They needed data to support their lobbying activities for resource allocation. Acquired Brain Injury Ireland and Headway are leaders with strong track records on awareness and political advocacy campaigns on brain injury in this country. For instance, they participated in lobbying for an extension to the National Rehabilitation Hospital in Leary, and at the 2016 election, they got a commitment from the government to further develop neurorehabilitation services. So 3 sources of funding then provided support for a 2-year study to focus on moderate to severe traumatic brain injury survivors. And we have 2 research assistants working full-time with us. And of course, the funders then were Health Research Board, Acquired Brain Injury Ireland, and Headway. So the impetus for the study, the burden of TBI in Ireland is unknown. What is evident, however, is that many TBI survivors have neither adequate nor timely access to rehabilitation services. Acquired Brain Injury Ireland and Headway are testimony to the lack of services for people with brain injury in this country, because both organisations were set up by families unable to find suitable services for their injured family members. So Professor Anthony Staines is the principal investigator and Dr. Brian Waldron is the clinical lead on the study. And then these are our partners and stakeholders. We have the 2 NGOs, Acquired Brain Injury and Headway, Cork University Hospital, Beaumont Hospital, and the National Rehabilitation Hospital in Dún Laoghaire. And then, of course, the Health Research Board for the funding. And on the DCU research team is with myself and Dr. Staines. Professor Staines is Professor Teresa Burke as well. We also have a research advisory group and a public and patient involvement panel. And there are international collaborators on the wider core team, on the research advisory group and the public and patient involvement panel. And last but certainly not least, a huge shout out to our 2 wonderful research assistants, Andrea Healy and Kate O'Donnell, who've been doing an absolutely amazing job. So in Ireland, there's approximately 150,000 people in need of neurorehabilitation, and only 44% of the beds that are required for specialist inpatient rehabilitation for those with brain injury are currently available. This is not actually limited to traumatic brain injury. Furthermore, Ireland falls well below the internationally recommended number of physical rehabilitation medical specialists, having only 9 in the country with an international recommendation of 27. Considerable gaps then in service provision, as well as excessively long waiting periods to access services are experienced by individuals with TBI in this country. Data from this study will provide the epidemiological evidence to support advocacy efforts towards systems of care and rehabilitation outlined in the Implementation Framework Health Services Executive. So the evidence suggests that in adults with an acquired brain injury, intensive and early access to neurorehabilitation promotes better outcomes and is cost effective. Timely access to acute care serves to limit the primary head injury and secondary complications, while access to ongoing rehabilitation can maximize functional recovery. The British Society of Rehabilitation Medicine and Rehabilitation Medicine Consultants in Acute Care, in their guidelines for the management of rehabilitation following serious brain injury, both acknowledge the critical role in early rehabilitation in particular. They recommend identifying the rehabilitation needs of the patient, directing the patient to appropriate rehabilitation services, and expediting referrals to such services where necessary. The British Society of Rehabilitation Medicine guidelines also propose that the rehabilitation pathway begins in the acute phase. And this is an area of care of most concern because of the evidence indicating better outcomes with intensive and particularly early rehabilitation. Rehabilitation services should be organised around the need rather than the diagnosis of the survivor, and the needs met under the care of the multidisciplinary team, preferably in the community setting. So study aims then were to calculate the incidence prevalence, mechanism of injury and disability of moderate to severe traumatic brain injury survivors, examine the pathways through rehabilitation for survivors of TBI in the Republic of Ireland, describe how people with TBI access rehabilitation and health services, and the experience of family members and carers of those with TBI is also explored. We do appreciate that concussion conundrum can result in long-term disabilities. However, the study was limited to moderate to severe TBI survivors as the focus was on their rehabilitation in particular. So we used a mixed methods observational cohort study design with purposeful sampling to select the participants. Participants with moderate to severe TBI were recruited through 2 brain injury service providers, the NGOs, 2 acute hospitals that provide neurosurgical services, the National Rehabilitation Hospital, and through social media. A questionnaire was administered to participants with TBI on 2 occasions, 6 months apart, and to a carer or family member on 1 occasion. So the injury severity then was determined per the literature as severe, being a participant who has a Glasgow Coma scale of less than 9, loss of consciousness for greater than 24 hours, or post-traumatic amnesia lasting greater than 1 week. And then moderate traumatic brain injury being the participant having a Glasgow Coma scale of between 9 and 12, loss of consciousness between 30 minutes and 24 hours, or post-traumatic amnesia that lasted between 24 hours and 1 week. So a lot of times we didn't have these measurements, so where they weren't available, positive findings on a CT or MRI is being used to determine the injury severity. So the inclusion criteria then were adults with moderate to severe traumatic brain injury, capacity to give consent was a very important factor, and resident in Ireland. And then the caregivers, also adults and non-professional caregivers or family members who provide support to individuals with TBI were selected. So that did eliminate any professional assistance. Clinicians at partner sites, which were Acquired Brain Injury Ireland, Headway, the National Rehabilitation Hospital, Beaumont Hospital and Cork University Hospital, identified potential participants who fit the inclusion criteria and invited them to participate in the study. 2 cohorts of TBI survivors were recruited. 1 cohort was recruited through the acute hospitals Beaumont and Cork. These survivors were at least 3 months post-injury. And in an attempt to collect data from the northeast of the country, we also had Letterkenny University Hospital on board, and they were very much ready to assist us. However, unfortunately, we were not able to secure ethical approval from the Schulte Hospital Group there for that. The second cohort were those who were at least 12 months post-injury. A cohort of family or carer members, carer or family members provided support who provided support to individuals with TBI were recruited through the participants with TBI to form dyads, although this was not always possible. So we will document both cohorts' rehabilitation pathways of care, assess the impact of TBI in the study participants and their caregivers' lives, and translate the research findings into a workable treatment knowledge plan. So participants were encouraged to complete the questionnaire in the format of an interview with one of the research assistants, Andrea or Kate, in person or on the phone. However, they were informed that they could choose to complete it independently online or hard copy if they preferred. Data were completed using Qualtrics software. So we started off with the questionnaire with the personal data, 34 questions with personal information, circumstances of injury, employment, rehabilitation, etc. And then 3 widely used standard instruments measuring quality of life with those with TBI survivors were used. The European Quality of Life 5-dimension 3-level version is a widely used measure of health-related quality of life. It has 5 dimensions of health, which are mobility, self-care, usual activities, pain, discomfort, and anxiety/depression. A visual analog scale makes this usable for our particular study population. Health states are derived by combining the values then related to the level of problems experienced in each dimension of the instrument. We also use the World Health Organization Quality of Life, BREF, which is a 26-item abbreviation of the entire 100-item instrument. It measures the physical, psychological, social relationships, and environment of the respondent, and it can provide subjective well-being insight into the effects of the disease state. Studies support the use of this instrument as being very suitable, particularly in our population. The European Brain Injury Questionnaire then was also used. It was developed specifically for use in brain injury patients and their relatives. It is also a self-evaluation of problems or difficulties that people sometimes experience in their lives. And so 9 domains are involved with this scale, with this instrument: somatic, cognitive, motivation, impulsivity, depression, isolation, physical, and communication, and core. And so we felt that this was a comprehensive approach using the many metrics to assess the quality of life of the TBI survivor. For the care then, we used the Mayo-Poland Adaptability Inventory 4, which was developed to document various cognitive, behavioral, and social challenges experienced by those who have acquired a brain injury. Carers also completed the World Health Organization Quality of Life instrument. And then finally, the burden scale for family caregivers used a 4-point Likert scale to assess levels of subjective burden among family members. The subjective burden in those who provide care for the critically ill has been found to significantly affect the emotional health, physical health, and mortality of the caregiver. So after the initial interview, a follow-up interview was conducted approximately 6 months using a shorter version that included the same standard measures. And this was designed to capture any changes in the rehabilitation pathway or changes in other aspects of the patient's life, of the participant's life, such as employment, health, quality of life, and outcomes after TBI. A healthcare survey was sent to the participants once a month between the first and second interviews as well for a 6-month period. And they received this survey via text or email or phone call. We wanted them to document any data on anything to do with healthcare services, how the services were used. We wanted them to record doctor visits, visits to rehabilitation or daycare centres, so that data relating to the rehabilitation pathway could be captured. So other data points then were the medical records of these of the participants, also the major trauma audit. Dr. Conor Deasy in Cork University Hospital is the clinical lead for the major trauma audit, and this actually sits within NOCA, the National Office of Clinical Audit. The HYPE data is also being used, and the National Physical and Sensory Disability Database, along with the Central Statistic Office. Obtaining this data would certainly not have been possible at all without our clinical partners. So we really thank them for their wonderful cooperation with this. So challenges then, well, they weren't quite as challenging as this guy. Nevertheless, we had 6 separate ethics applications, which were particularly challenging because of the nature of the study. And like I mentioned already, we couldn't actually ever get ethical approval for Letterkenny, unfortunately. Recruitment then, GDPR prohibited the research team from having direct access to potential participant contact details. Therefore, individuals and the partner sites were required to identify potential participants and ensure that they met the inclusion criteria. And then the partner sites sent invitation packs and coordinated potential participant queries. And thank you to Brian Waldron for dealing with many of those queries. The instructions then, the research team required the potential participant to follow instructions and make contact with them directly. However, potential participants who perhaps couldn't follow instructions or didn't have family members to assist them were missed from the
5 minutes left.
The dyad, thank you. The dyad, the research team required a dyad initially, but this was not always possible. So we had some of the survivors complete a questionnaire that included both questionnaires, a smaller version of that. And then medical records, we expected to recruit there. The medical records, we expected to recruit an early cohort, but unfortunately we couldn't get access to some of the medical records in one of the hospitals until 6 months out. So challenges then, the research team were unable to access the DCU post to obtain consent forms, which was the main method of participation, because we couldn't go on the DCU campus. Lockdown in March coincided with recruitment at the hospitals, which was significantly delayed. Individuals at the hospitals identified as assisting the team were redeployed, and the project materials were inaccessible. During lockdown, a project website was developed. There was a lot of interest in the website, however, not many people met the criteria, so it only yielded a small number of participants. And prior to COVID, interviews were completed face-to-face, but this had to be changed to phone and online. It was deemed effective via phone. Nevertheless, the full impact of not meeting the participants' face-to-face interviews will never be known. So COVID is continuing to cause issues as we're unable to travel for medical records to other parts of the country. And last but not least, COVID has actually altered the data as participants were unable to attend rehabilitation services. So I'll call on my esteemed colleague, Professor Anthony Staines, for the expected outcomes piece.
Surely. Okay, so the purpose of this study is to figure out how people move through rehabilitation. The focus is very much on pathways through rehabilitation, and particularly on the various timescales for those pathways. We do want to assess the burden of disease, but there's a fair amount already known about the burden of traumatic brain injury. While we will add to it, this is very much a piece of work focused on what do we need to do for rehabilitation. Next slide, please. So the data we're using is quite comprehensive: surveys, medical record data, and a range of routine data for a number of different organisations. One of the more disturbing things about the Irish Health Services is how little joined up patient information there is about how people move between organisations. And Brian Waldron alluded to this earlier today, and it's a problem that goes far beyond the TBI space. It affects really everybody. One of our other research agendas is integrated care and shared records, which certainly supports seamless transition of care. But we aim to put this material together to produce a picture of what's happening with people with TBI at the moment. Next slide, please. To date, we have completed 122 first interviews. We're still doing second interviews. We haven't collected as many first interviews as we had hoped for a variety of reasons, one of them being issues with access to records in one of the hospitals, and the other being COVID. The carer survey is proceeding ahead, and the majority of the people who've done first interviews with us are providing us with monthly information on their healthcare use, which will be very important. So we're making good progress with medical record abstraction. Our colleagues in Cork have very generously agreed to collect the data from Cork, which will make our lives enormously simpler, especially given COVID. And ABI Headway and the National Rehabilitation Hospital have been extremely helpful in allowing us to access their systems and helping us to use them. And we're still working with Beaumont to figure out the best way of doing that. Next slide, please. So we will have a range of results coming out of this, but we hope to be able to calculate disability adjusted life years due to traumatic brain injury. because we are collecting quality of life data. So we will have a certain amount of epidemiological data and a certain amount of quality of life data. And I'm well aware of the issues around using quality of life as a metric. But when you're discussing with health economists and trying to seek investment in services, it's often a powerful tool to have in your armory. Next slide, please. We hope to make our data accessible through the Irish Social Science Data Archive in a suitably anonymised format. And I think that can be done. It's probably relatively straightforward. We have asked permission from the participants for a follow-up in a few years' time. So we will be looking in due course for further funding to continue following this group of people. And we may be able to contribute this information to a registry on traumatic brain injury if such a creature is developed over the next few years. Next slide, please. Our major focus is on getting it out. We had hoped to get it out to the World Congress in Brain Injury in Dublin next year. I'm hoping that will happen. I'm hoping it will happen in person, but I'm not entirely optimistic that it will. And we will be developing a range of communications to other organizations that will find these services useful. And we will work on those in particular with ABI and Headway, who obviously know the system very well. And we will run a briefing in the Dáil for any interested parliamentarians to turn up and listen to our results. And we will tell you all about that before it happens. And that's it. So thank you. Thank you very much.